pillar that we have to do in order to get primary stability, 2 implants toward the base of the nose in order to get primary stability with the big cortical anchorage technique, and 2 implants in the posterior area. Those are the 6 implants, okay? 2 pterygoids, 2 tertian, and 2 in the front. So everything went very good. I could reach a good primary stability for what? For immediate loading. Because our aim is in 100% of cases to do and to deliver immediately something fixed. And this was the provisional that I immediately delivered after the surgery. And also I took a CBCT. Why? At that time I was not doing any kind of digital protocol, but I took the CBCT in order to check the position of the implant. And look at the right transsinus. Okay, this is the particular slice, and you see the apex is completely engaged in the canine pillar. So, was it a good transsinus implant? It was perfect in my opinion. Having a good primary stability, having the implant, the apex of the implant engaged in the canine pillar, and also the pterygoid were inside the pterygoid fossa. So everything went very, very well. But look what happened in time. After 3 months, I unscrewed the provisional, and 1 implant failed. Like Dr. Chu showed, the transsinus implants failed. Why? Because transsinus implants, in my opinion, are the most difficult implant that we can put, and also they have the less anchorage in the bone. So what did I do? I replaced immediately the transsinus with a short one, but without cutting the provisional. And why I didn't cut the provisional? Because I had the 2 pterygoid implants. So you understand that those 2 small implants in the back with high primary stability saved completely my rehabilitation. Okay, and also my reputation with the patient. This was the definitive, and look. Also nowadays, when I have to reach the pterygoid region, I don't put teeth sometimes. If the patient doesn't want the second molar, I only reach the pterygoid implant with the framework in order to be more cleanable, in order not to interfere with the cheek. Okay? Because the pterygoid implants and the pterygoid board gives you a lot of freedom. You can do whatever you want with the pterygoid. You are not obliged to put a tooth there. Okay? Good. So, I know that many of you, like for zygomatic implant, are scared about pterygoid implants. And you know which is the first thing that we have to do in order not to be scared in surgery, to know perfectly the anatomy and the surgical technique. Okay? So, first of all, we are going to analyze deeply the anatomy of the pterygoid region in order to understand in which area, in which anatomical field we are dealing. Then I'm going to show you little by little some clinical cases in order to make you familiar and aware of this surgical technique that in my opinion is the most important surgical technique that you have to know and to use in your office, because it will revolution the solution that you can offer to your patient. First of all, we are dealing with the posterior region of the maxilla. In the posterior region of the maxilla, we have the tuberosity of the maxilla, right? That usually is soft. Then we have the pterygoid plates and laminas, and between the pterygoid fossa and the pterygoid laminas, we have a bone in between. That is the palatine bone with its pyramidal process of the palatine bone. And why I'm underlining this bone? Because we call this implant pterygoid because it hangs inside the pterygoid fossa, but it's anchored in the palatine bone. especially in the pyramidal process of the palatine bone. That is the posterior pillar, like Matteo was showing to you. Canine pillar, zygomatic pillar, and the posterior one is called pterygoid pillar. Okay? Is it clear? Because it has to be really, really clear, this concept, in order to put these pterygoid implants without any fear. And this is the palatine bone, you see, between the tuberosity and the pterygoid fossa. Let's move on. We show watching this video. Okay, you see, in green we have the tuberosity. In blue we have the palatine bone. In yellow, the pterygoid fossa between the two pterygoid laminas. Okay? And what do we have inside the pterygoid fossa? What do we have? Only muscles. Okay? Because where are the arteries? The arteries are really far away. They are in the pterygopalatine fossa. That is completely a different anatomical region from the pterygoid fossa. They are two completely different countries. And we are going to see where is the pterygopalatine fossa. So from posterior, tuberosity, palatine bone, pterygoid fossa. Okay? Where we have only muscle. Looking from the lateral point of view, tuberosity, pyramidal process of the palatine bone, and lateral pterygoid lamina. Okay? So I was telling you where is the risky part and the risky artery. The risky artery is here in the pterygopalatine fossa. But the pterygopalatine fossa is very far away from the pterygoid fossa. Okay? And this artery is called the internal maxillary artery. That is the terminal branch of the external carotid artery. Okay? But to reach this fossa, we have to drill for more than 4 centimeters. And usually pterygoid implants are from 13 to 20 millimeters. Why? Because the medium length that we are going to use are 15 and 18. And up to 20, they are, or only in rare cases, they are useful. Usually with 18 millimeter or 15 millimeter, we reach our target point. Okay? And this is a video about the internal maxillary artery. You see, pterygoid fossa is here. The internal maxillary artery that enters inside the pterygopalatine fossa is a completely different anatomical region. Okay? So you have not to be scared about the internal maxillary artery because it's really far away. And even if you are drilling in a wrong, with a wrong direction, you cannot injure the internal maxillary artery. Okay? That is very important because if you know it, you are anchoring inside the world of the remote anchorages. Okay? Because pterygoid implants are different from zygomatic or the canine pillar implant, the nasal implants, because you don't see your ending point. Okay? So you have to understand what you are doing. So that's why for any surgery, but especially for pterygoid implants, the knowledge of anatomy is so important. Okay? Sorry, because I think that the computer